Thank you, Lisa, and thanks for inviting me today. It's a sign of a good conference when, just before lunch, there's only one person sleeping. I think the feedback's going to be, can you have a more comfortable carpet and clap more quietly, please? He's been very well behaved. Fantastic. So my name's Peter. I'm a GP. So on behalf of the medical profession, please accept my apologies. I've worked in Drumchapel in Glasgow for 17 years now. Drumchapel's a wonderful, rich community, which I could talk about for ages, fantastic history, but also a community that's experienced some of the worst difficulties of Scottish history of the last 50 years. So some of the best and the worst in Drumchapel. Garscadden Burn Medical Practice is in the health centre. We're just an ordinary little GP practice, and we named ourselves after the little river that runs behind the health centre, which you can see there. So lots of sites of natural beauty in Drumchapel as well. It's nice to get a day out from the office. This is what I'd normally be doing at this time, sitting down to a list of 60 odd letters and results to work my way through. So this is a letter about Andrea. Very typical handwritten letter from someone at a clinic. I don't know if you can read it. It's quite good handwriting. Diagnosis, fibromyalgia and osteoarthritis, possibly more. Bloods and X-ray arranged. Please prescribe amitriptyline, duloxetine, pregabalin and Versatis plasters. Yours sincerely. Now Dr. Y is, this is a real letter, although I obviously copied it out. Is a fantastic rheumatologist, very caring, but he knows and I know that that letter is not really the reality. So we scratch a bit behind that letter. Basically, Andrea has what Professor Stuart Mercer has helped us all to learn to call multimorbidity. So that's our diagnosis these days. And well, in amongst that multimorbidity is loneliness. So as I'm reading Dr. Y's letter and his recommendations for what I should prescribe, I guess I'm scratching my head to find out whether the diagnosis and the treatment match up. So is that prescription the correct prescription for a diagnosis of multimorbidity with all these factors? Now the best thing to do when you don't know what to do is to procrastinate. So let's procrastinate a little. So if we look at the Health and Wellbeing Survey from my locality in Glasgow, we find that people who live in Andrea's part of the world are 50% more likely to say they feel isolated from family and friends. So Andrea's certainly not on her own in having loneliness as one part of her diagnosis. Also 4 times more likely to say, I do not feel like I belong in my local area. So this is Andrea's context, but it's bigger than that. People who live in areas like Andrea's, on average, have 18 years less of healthy life expectancy. That's for men, it's slightly less for women. 38% more complex health problems, that's 5 or more long-term illnesses, and twice as many combined physical and mental health problems. So the first perspective I want to bring to this conference is that loneliness and social isolation are features of being poor and living with complex health problems. Scotland has one of the worst health inequalities records of Europe, and we have to understand that within that, loneliness and social isolation are one of the drivers that are creating health inequalities. So this conference is a conference about social justice and health inequality. And I hope that our research and our campaigning doesn't see deprivation and poverty in Scotland as just one extra facet to tag on to the end of loneliness. It's core to what it means to be lonely in Scotland today. Let's procrastinate a bit more. Still don't know what to do about Andrea. Hospital admissions. I'm not going to send her into hospital, that would be crazy, wouldn't it? So since 2007, in Glasgow, something happened to hospital admissions. Now, the story we usually hear on the news is that we're getting older. I find it hard to believe that we suddenly got older in 2007. Now, better minds than mine have puzzled over the question of hospital admissions, And one of those better minds is Dr. Helen Irvine, and I would urge you to become familiar with her work. So Dr. Helen Irvine has looked at the factors that have created this sudden increase in hospital admissions. And golly gosh, in that time, we've stopped spending money on social care. Surprise, surprise, people are going into hospital. We've also stopped spending money on district nurses. In 2007, there was a big reorganisation of nursing in Scotland, and the numbers of district nurses in Glasgow crashed, rock bottom. They've recovered slightly, but are still massively less than they were before 2007. In 2007 as well, there was a 1% drop in the percentage of NHS funding to general practice, and that has continued to deteriorate since then. These figures are slightly out of date, and in Scotland today we now spend just slightly above 7% of the entire NHS budget on general practice care. This is another way of looking at it. Bit of a complicated slide, so I'll talk you through it. The easiest one is the blue squares, the line that starts lower on the left and ends up at the top. That's the number of medical consultants in Scotland. The purple line that starts on the left and is fairly flat, that was the number of all GPs in Scotland until they stopped counting, which was in 2004. They gave up counting GPs in 2004, and now we just guess. The best guess is that we now have 3,262 full-time GPs in Scotland, which is 200 less than we had in 1996. We now have 4,500 specialists, which is 2,000 more than we had 20 years ago. So from having 1.5 times as many GPs, we now have 1.5 times as many consultants. Dr. Helen Irvine suggests that may have something to do with the sudden steep rise in 2007, which just coincidentally is when we started having more hospital consultants than we did have GPs. Recent survey of primary care, 90% of people working in primary care say they feel stressed by their work. That's 50% more than the NHS average. 8 in 10 have their sleep affected by their work. 1 in 5 reported a diagnosed mental health condition for which they are taking medication, I believe, which they associate with their work. And 8% admit to suicidal thoughts associated with their work. These are the people who are caring for the people. So I loved Sabina's slide about the carer running on empty. That's what this is talking about. Last complicated graph, and this is looking, the red and the blue lines show life expectancy and multiple chronic complex conditions. And there's a very steep rise between most affluent most affluent areas on the left and least affluent on the right. The black line that flat lines along the bottom is distribution of funding. Okay, so we do not fund general practice to meet need. So when Andrea's when I'm getting this letter about Andrea, not only is Andrea living in a community where these problems are far more prevalent, she's also coming to general practice that is struggling. Okay? So the easiest thing for me, to be honest, is say, damn it, I'll just prescribe those things. Professor Mercer has compared what GP consultations are like in deprived and affluent areas, and found that consultations are shorter, patients report less enablement, GPs report higher stress. And the people who report the lowest enablement are those who live in deprived areas and have psychosocial problems, precisely the people that we're talking about today. And GPs are perceived as being less empathic if they work in a deprived area. So again, apologies for being a GP in a deprived area. We're clearly less empathic. So perspective 2, let's be realistic when we talk about these things. People who are lonely, isolated, and living with long-term conditions rely heavily on community-based services, and these have been slashed in the last 10 years. Cuts to these services has resulted in costly and unsustainable growth in hospital admissions, and the impact of this has been most acute in areas of poverty. Now I'll let you into a secret. I'm a GP and I get called a gatekeeper. You heard that phrase before, gatekeeper to the NHS? Here's the secret. There isn't a gatekeeper. There's only a gate. Any of us can get into hospital today if we want. We've all got the imagination to blag our way into hospital. And if we don't, Google will help us find the symptoms. Why aren't we all trying to get into hospital? Because we've got something better to do. Okay. Now, huge number of people in Scotland live with long-term conditions, live with breathlessness, depression, pain, heart disease. If those people don't have anywhere, we only go to hospital as a last resort. No one or very few people choose to go through that gate. But as we take away all the reasons, all the people to turn to, all the supports, all the help, all the ones that listen to us, all the ones that take care of us, as we become more and more isolated in our little bubble, and then we go to see the GP, even they have got no time for me, where else is there to turn? Now, the last 10 years, our policy has to make a bigger and bigger field on the other side. Okay? We need to change that. This conference needs to change that. Let's make the environment in which people live one that looks after them, so they don't feel that they have no resort but to go to hospital. Procrastinating's over. We have a decision to make. What are we going to do? So here we are. We've thought about Andrea and all her situation, and the recommendation is that we prescribe her a combination of a 1960s antidepressant, a 1990s antidepressant, an epilepsy treatment, and a sticking plaster, in more ways than one. I thought I liked the irony of that. So how much would that cost? Well, that would cost £2,250 per year to put her on those combinations. Now, in many respects, I would then feel my job is done. I've given her the drugs. Andrea would feel, well, the doctor's done his best for me. Maybe I feel a little bit better. Yes, I feel really dizzy every time I stand up, and I can't remember my dog's name, but I feel a little bit better. And I quite like that patch because it makes everything feel numb round about there. It takes away that a bit. So, job done. 2,250 a year, maybe that's good. If Andrea were to end up in hospital with one of her conditions, £1,000 a night. But I don't think anybody in this room feels that that's really the way we should go. And I think the fact that we see nothing but increasing health inequalities, and for people like Andrea to end up in that kind of treatment is a disgrace. There's a gut feeling from GPs as well. I did a little survey around my colleagues about how they felt about social prescribing that Sabina was talking about, and this is what someone said: I didn't become a GP to spend my life prescribing pills. I became a GP to care for people. But all there is, we just work in the production line, come in the door, pop out the other side with your prescription, isn't it? Funnily enough, caring for people works. This is a wonderful study by Stuart Mercer called the Care Plus study. You just give GPs a little bit of extra time and ask them to sit and care for people. There you are. Not only did people get better compared to baseline, whereas a comparison people actually got worse. If you do ordinary care, people get worse. So we actually found out that caring for people works. I don't know if that's a groundbreaking study or not, but it seems like quite a good one to me. I'm going to give you two small examples of what caring for people might look like practically in primary care, because I know it's great to have campaigns and big pictures, but what do you actually do? How do you actually go about trying to care for people? One of them is the Govern SHIP program, which is based on the Care Plus study and gave some extra GP time, attached social workers and monthly meetings to talk about the most needy people and try and find answers. I'm just interested from that study, which is just a very early project, but they've looked at what do the GPs actually do with the extra time. Golf course, possibly? No, actually, what far and away the biggest thing they did with the extra time is just longer consultations, just spend time with people, time to listen, time to treat them like human beings. They actually visited people at home, which is quite incredible, but they also went through people's case records. They wrote letters or they did advocacy for them. They went to other meetings with other professionals to try and help them. Now, the program that I'm personally involved with is the Links Worker program, which you've heard alluded to before. And I'm not going to tell you in great detail about the Links Worker program, except to say there are two branches to it. One is creating a new role within the primary care team, which I have a Links Worker. A bit like we have a practice nurse and a GP and receptionists and healthcare assistants, we have a social care generalist, if you like, someone who can respond to those aspects that people come in with that have more to do with their personal life and their social life, who can sit down with people and try and help them to find solutions to that, or try and link them up to resources and other people in the community who might be able to help them. So that's a fantastic new role, a new skill base that we have, that we're trying out in the practice. But it's not enough just to parachute someone like that in to a practice that's perhaps on its knees and with the kind of statistics you saw before. So the other part of it is a practice journey. And at the centre of that practice journey is practice well-being. How do we as carers look after our own needs, and how do we become better at being empathic? Sabina's evidence is that we become less empathic as our own needs, as our adverse symptoms. And if I'm feeling stressed and isolated as a GP, then my ability to empathise with people is damaged. And we know very clearly that enablement doesn't happen without empathy in general practice. So that's just what I've been saying. It's a partnership between general practice and the third sector, which is fantastic. In terms of well-being, we've just published a report on what we've done on well-being, which I'd like you to look at it if you have the time. But in our own practice, we've been doing, one of the many things we've been doing is yoga once a week. Now this is a local charity, a local third sector organisation that does free yoga to our patients, but we buy their time to give us yoga, helps us. Because we use yoga, we then encourage our patients to use it, and by funding them, they've got greater capacity. So it seems like a nice little neat, virtuous circle. We're also trying to get better at informing people, for example, through our website, about what's available in the community, to try and help people find what they're looking for. Just very briefly, over the first 2 years, we've been more than 2,000 people across 7 practices who've seen the Links worker. The vast majority of them, the most deprived people in Scotland. These are the types of issues that they've talked about. Perhaps no great surprise in that slide. A year 1 audit, now this is retrospective, this isn't hard science, but found that 60% self-improved well-being, 25% a major improvement. This is just a little quote. I'm no longer a victim, I'm a survivor. I've met other people who similar things have happened to. I don't feel ashamed any longer, and I'm much stronger. Interesting, this is called the Safety Climate Survey. Every GP practice in Scotland fills this in every year. What are the things that help to create a safe GP practice? This is the change from before we started the programme to now, comparing the 7 practices that are doing this and Scotland. So, big improvement in communication. Now, it started from a higher base than for Scotland, which has also, interestingly, had an improvement. But for all other aspects, workload, leadership, teamwork, safety systems and learning, substantial improvement in these practices compared to the rest of Scotland. So something is happening in these practices by just simply being asked to think about their well-being. Now, there's a whole load, I could talk for hours and hours and hours. There's 2 types of evaluation being done. One is our internal learning, where we're just recording what we're doing, why we did it, what we might do differently next time. And that's 12 modules called a record of learning. The other is a much more formal study by Glasgow University comparing these practices to 8 comparison practices who aren't taking part in the programme, which will give more hard data. Now, so far that's given an interim report, but in 2017 there'll be the final report of that. So perspective 3 is that putting the person at the centre of care includes those who need services and those who provide them. Now that's Professor Lewis Ritchie. And I want to suggest that if the NHS is to survive, we have to invest in well-connected teams, small well-connected teams of health and social care generalists, and that's connected across third sector as well as general practice, who can provide compassionate, unconditional, long-term, person-centred care. So I've just given 2 examples of how that might look like in the future. They're not final product, but we need to start thinking practically, what is the future going to look like if it's going to help address the needs. Now, just to finish off, I'm not sure how we're doing for time. Excellent. One of the biggest aspects of, and possibly the reason I'm here today, biggest aspects of the Link Worker programme has been introducing protected learning times for the practices. So our practice has a protected learning time 1 Tuesday afternoon a month. Now, we set up a little patient group last year and we asked them to identify what health needs are we missing? Is there something that we're not hitting in the practice? And this little patient group immediately came up with the answer, loneliness. The one thing we all discovered we had in common is that we're lonely. And so we asked the little patient group if they would help us to put together learning for the practice to teach us about loneliness. And so we invited Sandra to come and meet with us as a practice, but we also invited our patients, our little patient group, to write down for us. They didn't yet have the confidence to come and speak to us as a group, but to write down for us what loneliness means. And I just want to finish really by perhaps giving you their words. I had asked them to come with me, but that's a big leap. So instead, they very kindly let me use their words, which are much more eloquent than my own. Loneliness seeps into your very being, blackening your world and transforming your thoughts to thoughts of despair, eroding your self-worth till you feel worthless. Unless you've suffered from loneliness, you cannot imagine the sense of complete isolation that comes with this misunderstood condition. Once loneliness enters your world, it can bring with it depression, anxiety, lack of self-esteem, and so much more. It is as if loneliness builds a wall around you. You cannot break out, and no outside contact can get in. Some of you may remember I had the privilege of speaking at the Befriending Network's conference. I don't remember if it was 2 or 3 years ago, and I spoke about someone called Linda. You probably don't remember. But Linda still comes to see me regularly. Linda is a real wordsmith. She stutters when she speaks. And she's a fantastic example of what Sabina was talking about earlier, about how loneliness leads to changes in your ability to communicate. She used to run a bar in Spain. She speaks 2 languages, and she's now become someone who just finds it so difficult to communicate. So she would have really struggled to stand up here. She wrote 2 pages for me. I'm toying with the idea of reading the whole lot, but I think we probably don't have time. But I'll maybe just, she's dissected out what Sabina described in terms of neurophysiology, that process of becoming isolated and having your ability to socialize damaged. And Linda sat down and almost dissected that out. She's described what Sabina described very accurately in her own experience. I'll maybe just read that part of what she's written. I know from experience how loneliness can affect your life. I'm 58 years old and have never lived on my own until 8 years ago when my mother passed away. I lived abroad for over 15 years, and apart from my sister and brother-in-law, I didn't know anyone in Glasgow. I felt alone, but it was bearable as I'd brought my dog with me. Having my dog really helped, as gradually while walking the dog, I got to know mother's neighbours. Sadly though, 2 years later, my dog had to be put down due to old age, and for the first time I was really on my own. That is when I really understood the meaning of loneliness. No more chatty walkies, I was on my own. Loneliness changes positivity to negativity, happiness to sadness, hope to despair. Your heart is broken and your hope is shattered. You look upon life as a burden instead of a pleasure. It's hell. Then slowly the depression sinks in, then the anxiety, then the agoraphobia. You no longer leave your home. Why bother? Where would you go? What would you do? On your own? No. The thought seems preposterous. So you end up sitting at home feeling more and more depressed. You start to wonder, what's the point of anything? Why get dressed? No one comes to visit. Why bother with a shower every day? No one comes to visit. So who cares what you look like? Why bother cooking a meal for one? I love my sister, but sometimes I dread the ringing of the phone and her name comes up on the caller list. I've nothing to talk about. I've done nothing and I've been nowhere. What can I say? I don't want her to realize how depressed I feel, so I say that everything's fine and I am fine, but we both know that's not true. My sister has her own family, her own life, her own problems, so I pretend I'm having a good day. What else can I do except be there for me? So what else can she do except be there for me? But medication helps, talking helps. But if someone could invent a pill to cure loneliness, they would be the richest, most famous and most popular person on the entire planet. Loneliness kills people one way or another. Now, Linda has discovered this tremendous ability to articulate her experience of loneliness. But we've also asked the group to explain to us what changes their life, how do you break down this wall? How can we help? Not by saying, pull yourself together, get out and meet people. You have to slowly melt the wall, surrounding the person through kindness, caring, listening, making them feel valued. This then leads to them valuing themselves, learning to trust again, like watering a seedling and very slowly watching it grow into a strong plant that flowers and can lift its face to the sun. I think when we're talking about primary care, about time, about listening, about care, that is what we're talking about. And what you're talking about today, that ability to gradually and slowly melt through the wall of loneliness. I love that image that this group have put together for us. It's not a quick fix. I think the reason why policymakers and doctors don't like it is because there's no quick fix. You don't have a pill for it. There's no triple therapy of duloxetine, pregabalin and versatis that you can stick on it that sorts it. And we don't like stuff like that. It's too hard. But this little group, just skip over that. That's another lovely little quote, but we'll... this little group have started meeting together. We just asked them to meet for a few weeks, but they found out that they all were lonely and they started to develop a friendship. It's a wonderful friendship. Someone, after several weeks, admitted that they had an addiction problem. And their response was, well, I'm addicted to chocolate, so we're both just the same. Breaking down barriers of prejudice, of stigma. One of them at Christmas decided to go around her neighbours and put letters through the doors and said, I'm lonely. If you're lonely on Christmas Day, will you come to my house? 8 people came to her house, and they now have a little street neighbourhood group who go bus journeys together. Now this little group, they want to extend that to others, but they're still very lonely, very anxious, struggling. They're being supported by one of our receptionists. We did put an application to the Social Isolation and Loneliness Fund, but we weren't successful. So I think, like so many other little grassroots, community-based things, these are the things that will transform loneliness and change people's lives. And what we need to understand is that if the big system, the big hospitals, the big secondary, tertiary care system is to work, we have to get it right in the community. We have to get people's lives right, enable people to support one another. They've got big dreams. They want to build a coffee shop, and they want to have a drop-in centre. As GP practices, we're a little bit overwhelmed because we didn't set out to do this. This happened by accident. So if any of you have any advice of how we help a little community group get going, that would be gratefully received. So that's just a little whistle-stop tour, some of the context and also some of the reality of primary care, and perhaps some of the things that can happen when you ask a GP practice to start looking after its own well-being and start thinking about the bigger picture of patients. A little bit unpredictable, a little bit scary, but very much worthwhile. Thank you.